Good morning and a warm welcome to all participants in Malaysia, the SEAMEO Network and affiliated country to IMR-SEAMEO Webinar Series 2024. Today, we are going to tell you how we have sustained the rheumatoid arthritis research for the past 20 years. Today, all of us are from the Institute for Medical Research, Malaysia. Before I start the presentations today, allow me to share with you about the Immunogenetic unit. In our unit, we conduct patients-oriented research that focus on patients' identified priority and to improve patients' care management outcome. We work very closely with the clinicians. We investigate the genetic, lifestyle, environment component and the immune responses against protein or antibody, which may be responsible for the disease development. Our research approaches include face-to-face interview, blood samples collections and investigations, the clinical assessment, as well as clinical data analysis. We analyze gene environment, gene-protein interactions, and study the clinical profile and treatment stratifications of patients. We are focusing on chronic inflammatory diseases and infectious diseases, such as rheumatoid arthritis that we will share today, the ankylosing spondylitis, the drug-induced hypersensitivity, chronic renal disease, and host susceptibility to dengue infection. Ladies and gentlemen, before our presentations will start, allow me to announce some housekeeping notes from the Secretariat. We will take your question at the end of both presentations. For those who wish to have the e-certificates of attendance, please click on the link shared in this YouTube. And don't forget to subscribe to NIH YouTube channel. Ladies and gentlemen, today we are joined by two speakers with different academic background, and they will share with us their experience and stories for the 2 decades research journey. Our first speaker is Dr. Nurul Aain, Ahmad Fauzi, who is a medical doctor from the Immunogenetic Unit AIRC, IMR. Ladies and gentlemen, in research, evidence rules the games. Dr. Aain will tell us how the study established, the challenges posted, and finally, through persistency and consistencies in science and medical research, the researchers were celebrating their first decade of milestone. Dr. Aain, the screen is yours.
All right, Bismillahirrahmanirrahim. Assalamualaikum, and a very good morning to everyone present today. First of all, let me give a warm thank you to Dr. Tu for the kind introduction. My name is Nurul Aain. I am a medical officer from Immunogenetic Unit, Allergy and Immunology Research Center, IMR. I've been here since 2016. And today it is a great pleasure and a privilege for me to actually talk about the first decade of our research journey in rheumatoid arthritis with my slot entitled Decade 1, Persisting Through Challenges, Celebrating Milestones. So before I bring you to the MyERA study, let me take you to travel to a country far away called Sweden. To the average Malaysian, Sweden is actually known for its flat-packed furniture in IKEA and also the Swedish meatballs. But today I'm not going to talk about that. I'm going to talk about something a little bit more interesting called the Swedish ERA study. So the Swedish ERA is an acronym. ERA stands for Epidemiological Investigation of Rheumatoid Arthritis. This study was conducted in Karolinska Institute in Stockholm, Sweden. This study aims to investigate possible risk factors of rheumatoid arthritis, which is a chronic disease causing severe suffering and functional disability. The main goal of this research project is to increase the understanding of which factors actually contribute to the development of this disease. The ERA study is actually a population-based case control study, and the aim of this study is to investigate which genetic and environmental factors may cause rheumatoid arthritis. All participants answer an extensive questionnaire, and a blood sample is taken for genetic and serological analysis. The data collection started actually way back in 1996 and is still in progress. To date, 3,500 cases and 5,300 controls have participated in the study. So we've traveled to Sweden. Now I'm going to bring you back to my homeland, my home country, Malaysia. So my great honor today is to talk about something that is very near and dear to our heart, which is the MyERA study. The MyERA study is a Malaysian epidemiological investigation of rheumatoid arthritis that is a collaboration between the countries of Malaysia and Sweden that started way back in 2004 and lasted till 2018. So how did it start? It actually started with Malaysian leaders actually traveling to Karolinska Institute in 1998. For us who work in the healthcare industry, we know Karolinska Institute as a premier center of excellence and also the Nobel Awarding Center for the Prize in Physiology and Medicine. So after returning from KI, our Malaysian leaders initiated this program called the Malaysian Nobel Laureate Program. Under this program, a bilateral collaboration with Karolinska Institute Sweden was established to collaborate on medical research and development, professional training, and PhD study programs. The collaborative efforts with KI actually involved a wide area of medical research, innovations, and commercialization. And the research areas include, among many, oncology, epidemiology, infection biology, and our main focus for today, rheumatoid arthritis. So From the Swedish ERA, 2 key persons were actually on board the MyERA study to both navigate and facilitate this Malaysian endeavour. These 2 professors are Professor Lars Klaskook and Professor Lars Alfredson, both senior professors in their respective fields of rheumatology and epidemiology. These 2 professors are also the principal investigators and the managing directors of the Swedish ERA study since 1996 and is still active in the field of rheumatoid arthritis research. From our shores is Datuk Dr. Shahnaz Murad, the principal investigator of the MyERA study. She was also the former director of IMR. And we also had the pleasure of having the help of Associate Professor Per Larsson, who is the official coordinator of this Sweden-Malaysia collaboration. So that is how the Malaysian epidemiological investigation of rheumatoid arthritis, or MyERA, started. But before I get into the nitty-gritty details of how we did it, okay, let me first talk a little bit about the disease of question today, which is rheumatoid arthritis. So RA is actually a chronic autoimmune disease. It affects about 1% of the global population and is actually 3 times more common in women than in men. The nature of how it affects the patient is actually called symmetrical polyarthritis, meaning it usually affects both sides of a body in a similar pattern and usually involving more than one joint, hence polyarthritis. It is unfortunately not just limited to joints, however, as it can affect the whole bodily system of a patient, making it a systemic disease. And usually other effects will affect systems like the lungs, the heart, and the eyes. If you can see the photo that I've inserted here today, the one on the left is the picture of a healthy subject's hands, quite normal. But the one on the right is actually the photo of the hands of an RA patient, and as you can see, with visible deformities present. So the figure I've inserted here is actually something comparing the normal joint to a joint affected by rheumatoid arthritis as compared to osteoarthritis. The nature or the pathophysiology of rheumatoid arthritis is actually autoimmune in nature, and so there will be bone loss, thickened synovial membrane, and eroded cartilage, and hence joint destruction is actually the hallmark of RA, usually involving the hand joints that cause severe disability and reduction in quality of life. In contrast, osteoarthritis is more degenerative in nature. So in the clinical setting, 2 diagnostic criteria are used. Previously, the 1987 American College of Rheumatology ACR criteria, and after that, it evolved into the ACR-EULAR 2010 criteria. So rheumatoid arthritis can actually be divided into 2. It can be either a seronegative rheumatoid arthritis or a seropositive rheumatoid arthritis. The term seropositivity actually refers to the presence of at least one of the 2 antibodies, which is either rheumatoid factor or anti-cyclic citrullinated peptide antibody, ACPA. Now, seropositivity of RA patients, okay, meaning RA patients are positive for rheumatoid factor or ACPA, they are considered to manifest a more aggressive disease course as compared to seronegative RA patients. In general, the exact etiology of RA is still unclear. However, causes stipulated include genetics and environmental factors. In terms of the genetics of RA, it has been determined that no single population is actually sufficient for fully uncovering the risk variants underlying rheumatoid arthritis in all populations. In other words, some common risk alleles are present across different populations. However, others are limited to certain ethnicities or populations. In the figure here, you can see the alleles that are actually colored yellow are the common risk alleles across different populations, and the ones in the many different colors are limited to certain populations. So, the burning question right now, why Malaysia? So, the geographical position of Malaysia actually and our history puts us at a place where we've developed into a multiracial and multicultural nation, okay, with 3 major ethnic populations, Malays, Chinese, and Indians. In other words, Malaysians, regardless whether you're Ahok or Mutu or Ali, right, we enjoy our teh tarik, we enjoy our roti canai, we enjoy our yamcha sessions, or we tapao them to go home. In other words, regardless of our ethnicities, we are all living as Malaysians. So this is actually providing us a unique opportunity to study the influence of similar environmental and lifestyle factors across different genetic backgrounds. So let's dive into our main focus of today, which is the MyERA study. The aim of the MyERA study is to study the risk factors for developing RA in Malaysia. We look into the genetic susceptibility, environmental exposures, socioeconomic factors, as well as lifestyle factors. And not only that, we try to see if there is any interaction between two of them. Okay, so how did we start? They say great things come from small beginnings, and that is also true for the MyERA study. It actually started in July 2005 with 5 small research grant projects totaling to the amount of only 25,000 ringgit Malaysia. In this effort, this kickoff of MyERA study was actually done by 3 junior medical doctors, 3 junior researchers, and they were all paired with 3 medical specialists to lead the effort. And from there on, within 5 years, they've actually grown into this international collaboration as you see in front of you today. This photo was taken in 2011. So let's look into the study design of the MyERA study. The MyERA study is a population-based case control study whereby RA cases diagnosed by rheumatologists were identified and then compared with community-matched controls. This is actually the first large Asian case control study performed in Malaysia involving early rheumatoid arthritis. MyERA was conducted in multiple centres throughout Peninsular Malaysia. And as you can see, the red pins are actually locations where cases were recruited. Blue pins indicated the community-matched controls, while the yellow pins indicated hospital-based controls. So the following are a few photos of what was actually done during the MyERA study. Here you can see face-to-face interviews of RA patients were conducted in rheumatology clinics by trained researchers. If you can see here, and if you still remember, that is Associate Professor Per Larsen from Karolinska Institute to help kick off the study. Cases were actually interviewed using a modified structured questionnaire. Here you can see the process of subject briefing, consent taking, demographic questions being asked, which includes monthly income, life events like how many pregnancies and how many deliveries, as well as a health assessment questionnaire, disability index, or HUG-DI interview. The HUG-DI questionnaire is actually a questionnaire used to assess the functional ability of a patient in performing day-to-day tasks. Some questions include, are you able to carry or lift a full glass of water to your mouth? Basically, patients will then give a score between 0 to 3 to tell us whether or not they're able to do it by themselves or with some help from other people. Okay, as you can see here, this photo shows blood sampling from consented RA cases for laboratory investigations. The picture on the far upper left corner is actually showing you the individually packed blood tubes, consumables that were actually packed from IMR that traveled with the researchers for them to easily sample the patients and controls. Here you can see that there is on-site plasma and serum separation, cell harvesting, and DNA extraction at the field. So why was this actually done? Usually per field trip will take about 4 days. So to ensure the maximum quality of our samples, okay, not only consumables but reagents as well as machines like our dry bath, like our vortexer, like our centrifuge, all of that traveled with our researchers. This is another photo showing blood processing at the field. And as you can see, we actually made the best out of our circumstances. I'd just like to share a very nice little quote that says, success is a little like wrestling a gorilla. You don't quit when you're tired, you quit when the gorilla is tired. And I think this is a testament to the dedication and the commitment of the MyERA study team. Okay, so that was regarding cases. What about our controls? So community controls or residential area matched, okay? Meaning if I have an RA case who is a Malay lady in her 50s living in Kota Baru, Kelantan, so I will also get from Kota Baru, Kelantan, a Malay lady in her 50s, okay, who is healthy to compare the results with. Okay, so these residential area match controls were identified with the help of public health nurses. And so we actually worked closely with public health nurses for community control recruitments. And as you can see, it's not an easy task. This is actually the picture of the houses that they actually went door to door to, okay, to recruit eligible community controls by public health nurses and researchers. And we are ever grateful for the public health nurses, as without them we would not have gained access to these homes to conduct interviews and to collect samples. In this photo, you can see match controls are being interviewed in their homes by trained researchers. It's a whole family affair. Okay, kids get involved, their siblings get involved. And in the photo in the far right corner, you can see that usually the ones who stay at home are housewives, right? And so when their baby is crying, right, we even help to take care of the baby while they answer our questionnaires. So we were really engaged with our communities. Here you can see the blood samples were obtained from all participants in the MyERA study for further serological analysis and genetic studies. Usually the subjects are all right with the blood sampling, and the kids are the one who's a little bit more dramatic. So they both enjoy being part of the study. So come rain or shine, our dedicated team of researchers actually weathered the rain to still go door to door for community controls. And for example, if the identified controls are not available during the day, they actually do return to their homes and their residential places where they were better able to receive us. And the photo on the right actually shows a steaming cup of coffee and buttered biscuits actually served to our researchers by these community controls. And I don't think I need to say any longer, a lot of preparation goes into conducting the field work. And so 2 weekly research meetings were conducted in IMR to strategize and plan for simultaneous multi-center fieldworks. This is a photo of a whiteboard depicting the job description of each person who's going out to the field. Okay, as a goal without a plan is just a wish. As you can see here, fieldwork preparations are being done by the EPID team. Individual refreshments are actually packed for our participants. For on-site sample processing, these are the fieldwork preparations done by the Immunogenetic team, which include our consumables, reagents, and machines. Here you can see that all participants' blood samples were processed and assayed for protein and genetic biomarkers. And these tests were actually performed in IMR Malaysia and also Karolinska Institute, Sweden. Currently, all collected biological samples, DNA, serum, and plasma are under the custodianship of IMR, Ministry of Health, Malaysia. Now, let me bring to you the most exciting part of my presentation today, which is selected MyERA study findings. So through the MyERA study, we actually recruited 1,235 cases and 1,625 controls. The pie chart you see in front of you today is the subjects stratified in terms of their ethnicities. So why did I bring that up? That's because through the MyERA study, we actually found that the Malaysian population are genetically different by their genetic makeup. And when you set that data against a global population, you can see here that Indians are actually closer and more similar to Caucasians as compared to Malays and Chinese. The Malays and Chinese are more closer and do overlap with the Chinese and Japanese population. This is actually a figure taken from a plain language summary we prepared in 2021, depicting the genetic profiling of the Malaysian Indian community as compared to other populations. As you can see, this phylogenetic tree illustration shows the relationships between Malaysian Indians and other populations, and they all exhibit different alleles. Now, this is one of our major outputs from the MyERA study, whereby, if you remember, in my earlier slides, I talked about seronegative and seropositive rheumatoid arthritis. So before 2008, the only way to diagnose a seropositive patient was by doing a test called rheumatoid factor test. If you were positive, then you were deemed seropositive RA. However, with the advent of our MyERA study, we actually established a new biomarker called anti-CCP as a diagnostic test for rheumatology clinics in Malaysia in 2009. This is actually a remarkable achievement, seeing that this component of anti-CCP positivity was included in the ACR and EULA criteria in 2010. So I've talked a little bit about the risk factor found in the blood, which is the antibody CCP. Now let me move on to lifestyle, genetics, and environmental factors associated with the development of RA. Some of the risk factors found to be of risk to RA include TRB1, shared epitope alleles, TNF-LTA genetic risk variants, and also PADI genes. Now, when we talk about genetics, right, there's something that we need to think about besides the genetic makeup of a patient, which is the lifestyle of the patient. So from our MyERA study, we found that if you are a male subject with the genetic predisposition to getting RA and you smoke, your likelihood of getting a seropositive RA is actually 25 times higher compared to someone who doesn't smoke. So this highlights to us the important factor of smoking. In terms of females, okay, generally in Malaysia, females don't smoke that much, right? So what is actually keeping the occurrence rate of RA still triple to that of males? So we found in our MyERA study, if you are a female with the genetic predisposition of RA and you are exposed to something called textile dust, which is usually found in factories where textile is produced, or if you work as a seamstress, for example, then your likelihood of getting seropositive RA is 39 times higher than if you were not exposed to textile dust. Another occupational exposure that we looked at was exposure to silica dust. Now, silica dust is actually found in places of work like construction sites. We found that if you are a male exposed to silica dust, your likelihood of getting a seropositive RA is twice higher than someone without silica dust exposure. However, when you add to that the lifestyle factor, which is smoking, your odds of getting seropositive RA is actually 7.5 times higher. We also looked into vector-borne viral infections endemic to Malaysia like chikungunya and dengue, and the possible relation to risk for getting RA. And we found actually no evidence to say that infection with dengue or chikungunya arboviruses, which is symptomatically a little bit similar to RA in that it manifests as joint pain. Okay, we found no evidence that the infection with dengue or chikungunya arbovirus actually contributes to the development of RA. We also looked into the association of number of live births with risk of developing RA, and we found that 3 or more live births were associated with decreased risk of developing RA. So, in summary, the main findings from the MyERA study was in terms of immunology findings, genetic findings, and also the risk factors found in lifestyle or environment. So now that I've walked you through our findings, let me share with you some of the milestones that we've been lucky enough to experience with the MyERA study. Now, the first milestone took place in a place called Blue Hall in Stockholm City Hall, whereby we actually celebrated the conference of 2 PhD degrees The first one was of Dr. Abkaria Yahyas, Doctor of Philosophy in Epidemiology, and Dr. Tu Chun Lai's PhD in Genetic Medicine. Next, let me bring you through a little bit of our conference papers and high-impact journal articles published from the MyERA study. These are some of the articles published in high-ranking journals across the years, with the latest one in 2022, where they actually used our data to conduct a multi-ancestry GWAS association study in RA. Here you can see our data is used as a proxy for the South Asian population. In terms of dissemination by press conferences, our findings of occupational textile dust exposure increasing the risk of RA in female patients was actually chosen by the British Medical Journal, to be disseminated through press conferences to multiple news outlets across different regions, in different languages. And in terms of our database, the data that we got from our healthy community controls, was actually shared worldwide into this allele frequencies database. And from there, we actually published 3 short population reports of the Malay, Chinese, and Indian population in Malaysia. And not only that, we actually spin off 2 research projects, in October 2016. The first project looked into the association or presence of anti-RA33 in seronegative RA patients. This was a collaboration with Hospital Selayang. And from there, 3 proceedings were actually published in these journals. This is the second spin-off project from the MyERA study, where we looked into serum antibodies to dengue and chikungunya infections and the risk of developing RA. And from this as well, our colleague actually obtained her PhD in medical sciences. More than a decade later, actually the data, an attestment to the robustness of the data from the MyERA study, actually saw us collaborating with multiple institutions, both local and international. The one on the right is actually a paper published in year 2021, whereby Malay healthy control data from the MyERA study was used to analyze and compare with Malay female SLE patients. The one on the right, published in Nature Communications Journal with an impact factor of 15 in 2020, actually saw our data being used as a proxy for the Japanese population. And so, as you can see, across the years, several collaborative meetings have been organized for this collaborative consortium in Stockholm, Sweden, and Kuala Lumpur, Malaysia, between 2008 to 2018. In 2017, we actually had the honor of hosting Associate Professor Leonid Pajikov during the 12th MOHAM Scientific Meeting. He was an invited speaker. So as you can see, MyERA truly started from humble beginnings, and it evolved over the years from a national research to an international collaboration with our involvement in the International RA Genetic Consortium. With the MyERA study, we actually obtained several awards and recognition. Some of them include in 2008, the JCR Japanese College of Rheumatology International Scholarship. In 2014, we won the Ministry of Health NIH Best Researcher Award. In 2016, the NIH Golden Penna Award. So in conclusion, the MyERA research findings have been presented in several local and international conferences and also published in many international journals and received several recognitions. As my presentation has shown all of us today, that this MyERA effort did not just start from one person, nor is it the result or the fruit of one unit or one organization, but rather it is a collaboration across multiple different services in the KKM, local as well as international institutions like Karolinska, which reminds me of something shared by our former IMR director, Dr. Fazila Kamaluddin in 2016, where she said, if you want to move fast, you move alone. But if you want to move far, you move together. And all of this is also to say that any achievements coming from the MyERA study did not happen without the support and without the guidance of our mentors and our seniors. And as Isaac Newton said, if I have seen further, it is by standing on the shoulders of giants. Here I'd like to acknowledge the many people who have contributed directly or indirectly to the MyERA study. Our rheumatologists across Malaysia, our collaborators from Karolinska Institute Sweden and Beijing, China, our colleagues in ARC, IMR and Epidemiology Unit Malaysia, as well as our drivers. And of course, this would not have been possible without the involvement of all participants of the MyERA study. I would like to also thank our research funding agencies listed here, especially the Ministry of Health Malaysia and the Swedish National Research Council for supporting this study. I think that's all from me today. Thank you very much, and back to you, Dr. Tu.
Thank you very much, Dr. Aain, for the very insightful and interesting sharing of the research for the past 1 decade. If you have any question to Dr. Nurul Aain, please submit them through the links provided in the channel. Ladies and gentlemen, once a young boy told the researcher that she can only achieve what she believes, and whenever there's a will, there's a way. So that brings the research team to the next decades of the research. Our next speaker is Dr. Siti Aisyah, Abdul Ahmad, a research officer with a doctorate degree. Dr. Siti Aisyah is also the members of Immunogenetic unit since 2019. Dr. Siti will enlighten us on the renewed commitment in the research, which is from the bedsides to the bench and back to the bedsides, from transitional to stratifications and thereafter personalized medicine research. Dr. Siti, the screen is yours.
Thank you, Dr. Tu, for the introduction. Assalamualaikum and good morning. My name is Siti Aisyah. I'm a research officer from the Immunogenetic unit of AIRC, IMR. So now I will talk about the second decade of our rheumatoid arthritis research. The title of my presentation is Decade 2, a renewed commitment to continuous progress. So just now, Dr. Aain already talked about the MyERA studies, where we focus on translational medicine and risk factors identification. The European Society for Translational Medicine defines translational medicine as an interdisciplinary branch of the biomedical field supported by 3 main pillars: benchside, bedside, and community. The goal is to combine disciplines, resources, expertise, and techniques within these pillars to promote enhancements in prevention, diagnosis, and therapies. A one-size-fits-all approach to medicine is the traditional practice in medical treatments. This approach is based on broad population average. However, in reality, one size does not fit all, as different patients have different response to treatment. Moving on from this approach, we have stratified medicine, where patients are grouped based on several characteristics. The Academy of Medical Sciences defines stratified medicine as the grouping of patients based on risk of disease or response to therapy by using diagnostic tests or techniques. After celebrating the milestone in MyERA, we wanted to renew our research commitment by conducting a new study we called MyRAPID. MyRAPID was conducted between 2018 until 2021 where we focused on stratified medicine and clinical phenotype profiling. So MyRAPID is a 10-year follow-up study where approximately 400 patients from the MyERA study were revisited between 2018 and 2021. This is the study design and workflow for the MyRAPID study. After MyERA, we observed that 1/3 of the patients did not respond to treatment. And you wonder what happened. So that's why we wanted to conduct this 10-year follow-up research. In MyRAPID, eligible patients from the MyERA study were randomly selected to see their disease progression over 10 years. The study sites for MyRAPID includes several rheumatology centres in the Peninsular Malaysia. When I first joined the Immunogenetic unit in 2019, the team was in a very active stage of recruitment. And I remember my first hospital visit for the study was to Hospital Putrajaya. The first picture shows a scene from Hospital Putrajaya where you can see that our rheumatologist, Dr Nurul Aain, was telling the patients about the study. So in MyRAPID, we called back our MyERA patients batches by batches to see their progression over the 10 years by giving them to answer standard questionnaires. The questionnaires and subject recruitment flow was basically more or less similar to the first decade, where the rheumatologist will clinically assess the patients. So in MyRAPID, we observed that the patient's conditions were much more severe compared to when we first saw them in MyERA. For example, in this picture, we can see that this patient had rheumatoid nodules forming over parts of his body. And in this picture, we can see that the patient's hand had started to deform. For our part, we would do blood collection and clinical data retrieval. During the COVID-19 pandemic, we still continue our research, so our team had to wear full personal protective equipment during hospital visits. For clinical data retrieval, each patient's clinical notes from the time of diagnosis until the present time were read and transcribed into the clinical data retrieval form. For some patients, the disease duration could be up to 15 years or more, so we have to read all the clinical data and transcribe it into our forms. And then we would bring the blood samples back to our lab for manual blood processing, and then also conducting lab procedures, which mainly include the ELISA test. The results from this study were analysed, and the findings were already presented at several national and international conferences. Some of the findings include serological findings, where we found the antibodies profile changed over the 10 years, particularly for seronegative sustainers. We also found that 1/5 of overall RA patients experienced conversion during the 10 years follow-up. This poster was presented during the 22nd INIH Scientific Conference and won first place in the e-poster presentation. In terms of clinical findings, our data showed that older age and smoking history were significantly associated with RA patients with pulmonary fibrosis. After MyRAPID, we found out that while 2/3 of the RA patients were clinically in remission, 1/3 of these patients are still having moderate to severe disease activity. These patients are considered difficult to treat RA due to multiple drug failure. So these patients remain on ineffective therapy for a longer period of time. So MyRAPID marks the first few years of the second decade after MyERA, where in terms of medication, you can see that one size definitely does not fit all, as these different patients responded differently to medications. While MyRAPID was still ongoing, we received a new call from our stakeholders. Dr. Moliza, the National Head of Rheumatology, informed us on the importance of the choice of the first biologic demands. Her team from Hospital Selayang presented this abstract during the 22nd APLA Congress. In this abstract, they shared their finding from Hospital Selayang where they found that out of all the patients that are taking biologic DMARDs from 2000 until 2020, only 27% of the patients retained on the same biologic DMARDs. 43% of the patients required a substitute, while another 30% had to discontinue the therapy due to reasons such as adverse events or funding issues. Now let me give you some brief idea regarding the in terms of RA medications. So NSAIDs and steroids are commonly used by the RA patients to treat chronic pain due to inflammation. However, these medications can only offer temporary relief and do not slow down the progression of RA. The disease-modifying anti-rheumatic drugs or DMARDs, on the other hand, help preserve joints by blocking inflammation and slowing down the RA progression. There are three types of DMARDs. The first one is conventional synthetic DMARDs, which is the first-line therapy for RA patients. The second one is biologic DMARDs, which specifically target immune cells involved in the pathogenesis of RA. The third one is targeted synthetic DMARDs, which are a type of small molecules which target a key step in the Janus kinase pathway. However, B-DMARDs and TS-DMARDs are costly. For example, in this snapshot of zakat application for the purchase of etanercept, which is a type of B-DMARD, we can see that 6 bottles of etanercept can cost up to Rm23,000 ringgit. And this is the price during 2014, so I'm sure the price is much more higher by now. So most of patients are depending on government supports and funding agencies to buy their medication. So now let's look at the Malaysian scenario. In Malaysia, approximately 75% of RA patients on biologics are earning Rm3,000 and below. The National Inflammatory Arthritis Registry on NIA reported that only 30% of the RA patients are full-time employed and more than 50% of them are non-employed or homemaker. In terms of B-DMARDs continuation, in a real-life setting, approximately 54% of B-DMARD treated RA patients experience drug discontinuation due to inefficacy or adverse events, and only low clinical remission rate was observed. During our meeting with Dr. Moliza in 2021, she voiced out her concerns regarding this issue. In her words, she said, "If I have limited resources, which medication should I choose for my patients? How do I know which one is the most effective?" So the answer to her question lies in precision medicine. In precision medicine, patients are individually profiled according to these factors. Precision medicine ensures delivery of the right intervention to the right patient at the right time. So with that in mind, again, we wanted to renew our commitment by conducting a new study we called the BORA study. BORA study was started in 2021 and is expected to end in 2025. So in this study, we are going towards precision medicine, where we are looking at the safety and clinical efficacy of biologic DMARDs and targeted synthetic DMARDs. BORA study is a prospective longitudinal cohort study where the same participants are followed over a period of time. So the rheumatologist will pre-identify their patients who are about to be started on B-DMARDs or targeted synthetic DMARDs, and they will inform us regarding these patients, and then we will go to the hospitals and meet the patients. So the patients are grouped into 3 different groups. Group 1 are patients who are taking TNF inhibitors, which is a type of B-DMARD. Group 2 are patients who are taking non-TNF inhibitors, which is also a type of B-DMARD, but with a different mode of action. Group 3 are patients taking TS-DMARDs, or also known as JAK inhibitors. So in this study, we have a total of 6 visits within a period of 1 year. Meaning we will see every patient for a period of 1 year, and within that 1 year, we will meet them for 6 times. So for the first visit or the baseline visit, we will collect the patient's blood before they take their first dose of medication. And then for the second visit, we will meet the patient 4 weeks after they took their first dose of medication. Study visit 3 will be 12 weeks after. Study visit 4 will be 24 weeks after. Study visit 5 will be 36 weeks after. And study visit 6 will be 52 weeks after. Blood collection will be conducted during study visit 1 until study visit 4, while data collection will be conducted throughout the study. So this timeline applies to each patient. And bear in mind that the study visit 1 will not be the same for each patient, so this timeline can overlap between patients. So we are aiming to get a total of 240 patients. And Dr. Moliza suggested that we include all the rheumatology centers in Malaysia to make this into a national study. So with so many hospitals involved and many study visits that are overlapping among each other, we have to carefully plan our monthly schedule. So in our office, we have this board where we will put up our names and all the places that we have to go. And each one of us will have our own planner where we note down all the patients' appointments. So it is important to have an updated planner so that we won't miss any of the patients' appointments. Our biggest challenge in terms of field trip planning would be during the months of December and January every year, as we won't have any research assistants to help us. So Dr. Tu, Dr. Aain and myself really had to push ourselves for these field trips to make it work somehow. For example, on the 5th of January last year, Dr. Aain had to cover Hospital Putrajaya in the morning, and then in the afternoon she had to go to Hospital Serdang, while Dr. Tu went to Hospital Melaka right after she came back from Penang the day before, because I had to travel to Kelantan to see our patients there. So this is just to give you an idea of how packed our days can be. At every end of the week, we have to prepare our recruitment trolleys that are for the different centers that we are going to. Okay, with the capacity of 3 permanent staff and 2 research assistants, we have travelled throughout Malaysia from north to south and from west to east. Since the initiation of the study in 2021, we have made a total of 420 trips, with 187 trips within the Klang Valley and 233 trips outside of Klang Valley. So at sites, the patients will be assessed by the rheumatologist, while our team will conduct the study briefing and interview sessions as well as blood taking. So sometimes the patients were unable to come to their hospital visits, so we had to go to their house and collect their blood, as it is crucial for us to comply to our study timeline. Lab procedures for this study includes blood processing, DNA extraction, RNA extraction, HRA genotyping, and also gene expression. So this study involved a lot of data collection, as we have many hospitals and study visits to cover. So at site, we would collect the patient's data and transcribe the patient's clinical notes and medication history since diagnosis until the present time. So that's why it's important for us to have a comprehensive data retrieval form so that we can capture all the necessary information needed for each patient. So we designed separate booklets for each visit, and each patient will have their own folder, where at the end of the visit, these booklets will be kept in the folder from the first visit up until their last visit. These are pictures of our patients who had completed their final visit. So these patients have been with us for a period of 1 year, and they really committed in coming to their study visits. As of now, we have about 90 patients who had completed their 6 visits. So at the end of their final visit, we would give each one of them a souvenir mark as a token of appreciation for their willingness to join our study and stay with us for a period of 1 year. So the clinical assessment data for 50 subjects who had completed their 1 year study period were analysed, and the preliminary results were presented at Monash Initiate 2023 conference. The data showed that there is a significant clinical improvement in terms of clinical composite measures and DAS28-CRP in RA patients treated with JAK inhibitors within 1 month of treatment. This poster won Best Poster Award in the Public Health category during that conference. So finally, we would like to highlight the ultimate goal of the MyERA Rapid and BORA study, which is to find the right drug for the right patient at the right dosage. To talk about 20 years of research within this short period of time can never be enough. However, I hope by sharing my experience in conducting patient-oriented studies can give you an insight on how it is actually done. Finally, we would like to acknowledge our rheumatologists from the MyRAPID and BORA study group, our collaborators from NIH, our former and current research assistants, our NIH drivers, and last but not least, all participants of the MyRAPID and BORA studies for their willingness to be a part of our research journey. Thank you. Back to you, Dr. Tu.
Thank you, Dr. Siti Aisyah, for a very eye-opening presentations. If you have questions, we will take it a little bit later. So I will try to recap the audience about what have been happened for the last 45 minutes. So this is the first decade of our research, whereby we have started with very small grant research projects, moving on to pursue 2 PhD in Karolinska, and finally we extend our research. Finally, we extend our research to be part of the Rheumatoid Arthritis Genetic International Consortium, which called RASI. So in 2013, we started to plan our future for the next decade of the research. What we do is we divided our dream into 3 different areas, which is bioinformatics, the clinical follow-up for disease progressions, and also to perform experimental functional studies on our patients' samples. So as you can see now that we have completed the bioinformatic analysis and published the papers. We also have completed the disease progressions study, whereby we have revisited our first decade's patients after 10 years of disease treatments in various hospitals. And now we are actively engaged with the treatment response research, which is a prospective studies. Ladies and gentlemen, this slides will show you how we have put this rheumatoid arthritis research into a program. This slide shows various areas that has been explored. As you can see, it was indicated by different colors. Some of the colors indicates that the study has been completed. However, we have still a long way to go for analyzing the data and disseminating the findings. Ladies and gentlemen, as for today's, I would like to share with you that within the last 20 years, we have conducted 15 research projects. The researcher has received, the researcher as well as the clinician, they have received 41 research awards from various conferences. 66 papers has been published as original research article or proceedings. 81 scientific presentations was done locally and internationally, whereby 50 of the presentations is internationals, 31 is a local. And last but not least, 2 researchers have obtained their PhD from Karolinska Institute, Sweden, and 1 receiving her PhD from RCMP Uni KL. Ladies and gentlemen, without people's money, there will be no research. So we are very grateful to our participants, collaborators, funding agency for their trust and support throughout these years to make this project a success journey for all of us. So we are prepared to take your question from now. It seems that we already have some question from the audience. Let me see. Okay, we have the first question to Dr. Aain. Considering this research has been sustained for more than 20 years, do you see yourself or your team moving on from the field of RA? A lot of findings has been reported. Isn't it a time for you to explore other ventures outside of your comfort zone? Dr. Aain, please.
All right. Thank you very much to our member of the audience who asked this question. Thank you very much, Dr. Tu. So this question is actually a question that I myself asked when I joined this research group back in 2016. At that time point, I saw how much has been achieved and how much findings have been reported. And I asked myself, do we really need another project on rheumatoid arthritis? However, as I've been actively involved in the field of rheumatoid arthritis research, at least in the context of our research group, my question quickly changed from what else is there to where do I start? Because the nature of our work is actually clinical-oriented research, whereby we work closely with clinicians and we tackle the research gaps that they identify as they come. And so I think from our presentation today, where I had the pleasure of talking about MyERA study, and Dr. Aisyah actually presented what we're currently doing with the BORA study and the MyRAPID study, I think that's a testament more than anything towards our continued persistence in exploring this niche area and more, more effort and more continued research is actually needed. So rather than comfort zone, I think it's more of a niche area, and I think not only we shouldn't consider stopping, but rather we should continue to be persistent in this area. Thank you.
Thank you, Dr. Aain. There are more questions coming in, as I can see here. So maybe the next question I will give it to Dr. Aisyah. I see that your research involves traveling to a lot of places, more than almost 500 trips in total. What are the challenges that you face in conducting the study?
Okay, thank you for the answer. Well, for me, I think I would say the biggest challenge would be in terms of manpower. So because each year we were only provided with 2 research assistants and we have so many hospitals to cover. So with only the capacity of 3 permanent staff and 2 research assistants, we have to travel throughout Malaysia and it can be tiring at times. However, we are lucky that we don't have to drive to all these places by ourselves. So that's why we are very grateful for our NIH drivers, especially their supervisor, Encik Rijal, for never failing to arrange their schedule to fit ours. And in terms of resources, we have limited budget for this study, so we really have to strategize our budget, and we really have to save our budget, and especially so that's why during our field trips we would only stay at 3-star hotels so that we can save more and can go to more places. So I think that's the biggest challenge that we have to face in conducting this study, especially the BORA study. Thank you.
Thank you, Dr. Siti. To conduct a 20 years research is not easy. We have challenges. We have our bottleneck, but still, we should not stop there. We should move on, take the challenge, and never give up. So I'm afraid that that's all the time that we have for the Q&A sessions. However, if you have any additional question, we will reply to you, or we will answer your question through emails with the link provided in this YouTube. We hope that you enjoy our sessions today, and this webinar have shed lights to some of you regarding what we have, what kind of research that we have conducted in IMR. So we hope that it does spark your interest in our research, and we could initiate collaborations with you in the near futures. With that, ladies and gentlemen, now we have come to the end of the webinar sessions. We thank all the participants for your support to make this session a successful one. Until then, take care, stay safe, and happy Women's Day.